All right, peeps, let's do some more Invictus stuff. I'm going to do some multiple choice questions. But before we start, a couple of things. First of all, the pity. You watching it? Come on, the show is fantastic. It's getting great reviews. The team over there has done an amazing job. I'm so excited that MRAP, Corpenian, we are official collaborators now. I've been consulting with Joe Sachs, who really deserves all of the credit for how well that medicine has done. He's an amazing ER doc. My attending at UCLA. And now I get to actually sit in the waiting room, in the writer's room, which has been an amazing experience to help sort of keep this thing going. It's amazing. But if you're triggered by it, if you're getting PTSD from this thing, that's not abnormal. But it means that you need to get some help. So if you haven't been getting help, there's a lot of new therapies now. It's not just talk therapy. It's not just SSRIs. There's ketamine, which I have used and has been incredible for me. So if you're at that place, ketamine, fantastic. We've talked about it on Dirty White Coat, our sister program, of all of the different things there. So don't screw around. This is not a normal job, okay? It requires you to get self-care, so please do that, okay? It's really, really important. So what I want to do today, I've got a bit of a scratchy throat. I've got the salsa water. What I want to do today is some questions. So if you're listening, it's probably best to click on the link below and go over to the YouTube channel. As we are developing this program and all the faculty are starting to shoot their stuff and we're going to try and get this out as quick as we can, I want to try different techniques here on the free version of the podcast so you can give us some feedback about what you'd like to see in the future. So this is doing some questions. And these questions are all going to be on the same topic, but I'm going to use it as a way to highlight what I think are some of the most important features of the disease and what you might have on the exam. So here's question 1. 45-year-old with a history of injection drug use, high risk, presents with severe left arm pain. Severe left arm pain, okay? So this is the giveaway as to what this is. Swelling, erythema, 2 days, vital signs, heart rate of 110, temperature 8 febrile, blood pressure of 100 on 60. 45-year-old, that's pretty low. Physical exams, woody edema, no crepitus. What is the next most appropriate step? So what you're supposed to do is work out what's going on here. So you've got an IV drug user, you've got severe arm pain, and you've got this woody edema. That is a necrotizing infection until proven otherwise. So if it's a necrotizing infection, what is the next best step in management? These drive me crazy because obviously in the real world, what you do is we have 4 things at once. You get an IV and you start the fluid, you start the antibiotics. You probably are going to get some imaging because that's the way the surgeons roll these days. And you're going to call the surgeon at the same time. But the right answer in the textbooks, and if the world was a better place, would be what? So A, administer oral antibiotics and discharge for follow-up. I don't think so. They're trying to tell you this guy's sick. Obtain a plain film and wait for results. I don't think so. Plain films in necrotizing infections have a very low sensitivity. If there's gas and stuff in there, great, but it's not there all the time. Consult surgery immediately for operative exploration. That is the right answer. That's obviously not what happens in the real world a lot of the time, but that's the right answer. Or start IV fluids and observe for 6 hours. That might be a reasonable answer in cases where I'm not sure what's going on. I don't think it's a necrotizing infection. And the surgeon's far away. I might just kick them in the emergency department and observe them. And I've done that many times in my career. And most of the time it's nothing. And they don't get worse and they're fine. But I've got a couple of really sad cases where they got worse in front of me and I could call the surgeon and say, oh, look, I know you're an hour away, but start driving the fast German car because this person in the last hour has gotten a lot sicker and that cellulitis thing is spreading. Come on down. Quick drink of the salsa water. Delicious. Here's question 2. Which of the following are considered hard findings of necrotizing soft tissue infection on physical examination? In this case, a hard finding is a finding which strongly suggests the diagnosis of necrotizing fasciitis. So is it erythema and warmth? No, very non-specific. Cellulitis can do it, bug bites can do it, very non-specific. Hemorrhagic bullae? Yes. In the face of somebody where you think this is an infection, hemorrhagic bullae are a huge concern for necrotizing fasciitis. This is underneath the dermal layer and now it's bubbling up bad. Do you like that scientific explanation? Localized tenderness, very non-specific. Mild swelling, very non-specific. So it's the hemorrhagic bullae which are very concerning for necrotizing infections. And the other one is obviously crepitus. If you push on the wound, it goes hugely concerning gas-forming organism. Likelihood of necrotizing fasciitis goes up substantially. Let's do another one. This is a 32-year-old female who presents with severe perineal pain and swelling 3 days after childbirth. Her labs show a white count of 28, which is very high, a sodium of 132, which is a little bit low, and a CT scan reveals fascial gas in the perineal area. This is a problem. Which antibiotic regimen is the most appropriate to initiate immediately? So on this one, they're like saying, yeah, of course this person's going to go to the OR, but we're going to start the antibiotics. So one of the key teaching things here is that clindamycin in animal studies seems to reduce sepsis, maybe even reduce mortality, perhaps by reducing the production of toxin. So in a lot of these necrotizing infections of various forms, clindamycin is suggested by the ID expert. So I look down the list now. I want broad spectrum because this can be polymicrobial. So you want broad spectrum. It can also just be strep A, but you don't usually know that until later. And clindamycin is the regimen that I have. So it's Clinda plus broad spectrum. So the best one here is not ceftriaxone alone, but clindamycin, piptazobanc, linezolid by itself, no. Metronidazole by itself, no. So I look for Clinda plus very broad spectrum as the right answer for these necrotizing infections when they're asking about the antimicrobials. Let's do another one. 60-year-old diabetic male presents with a foot infection. Okay, we see a lot of those people. But in this case, he's had febrile, but he has a lactate of 5 and is hypotensive. Which of the following imaging modalities is most appropriate? We just talked about the fact that if you're really concerned, this person needs to go to the OR. Forget the imaging modality. Having said that, a lot of the time it's hard to make the diagnosis. So do you want to get a plain film? We talked about it. Plain films are not very sensitive. So if you do it and it's positive, fine. But don't screw around with this thing. It's not very sensitive. MRI is actually very good. The problem with MRI is it takes a long time and often is a far distance away. So that is really not the answer in the vast majority of cases. Contrast-enhanced CT, or even non-contrast-enhanced CT, as a tiebreaker, is really good. It has a very high sensitivity. It's not 100%, but it's very good. Or point-of-care ultrasound. Right now, that is not the answer, but the point-of-care ultrasound people are getting better all the time. So maybe that one day that will be. So CT scan is pretty dang good. In Compendium, they suggest that the sensitivity is over 90%. Not 100, it's over 90. So here's another one. Which of the following historical risk factors is the least likely to be a risk factor for necrotizing fasciitis? A, recent minor wound from gardening. That can certainly do it. Any minor wound, port of entry, bugs can get in there. That can be a problem. Varicella infection, same thing. Varicella, chickenpox, scratchy. It's the kids, the adults will often get a little bit of cellulitis. And that can turn necrotizing, so that's bad. And then probably a little bit immune suppressed from that infection. Hypertension is not a known risk factor for necrotizing infections, and injection drug use absolutely is probably the highest risk factor. Do you have time for one more? I need a little drinking here. I think we'll do part 2 of this because there's more on that I want to do. So here's a 50-year-old male with cirrhosis who presents with rapid onset of leg swelling and pain after a fishing trip in coastal waters. So this is a classic case. You've got cirrhosis, you've got a leg edema probably from your cirrhosis, and now you're in a coastal fishing trip. He's hypotensive and he has bulla on exam. Okay, so he's sick and they're talking about bulla, so they're thinking about necrotizing infections. Which pathogen is most likely responsible and what additional antibiotics should be considered? And so here are the answers. Group A strep and clindamycin. Yeah, I'll let those two together. That's not an unreasonable thing, but this is not coastal waters. This is what they're trying to get. I got it from the coastal waters. Vibrio vulnificus classically occurs in the waters of the coast of the seas. And doxy is the treatment, as well as broad spectrum, but you would add doxy to that person. There's another Clostridium species here, and vancomycin, and there's MRSA and the linezolid, but I'm discounting all of these because it said coastal waters, and I know that's Vibrio. So this is one of those examples where a little bit of knowledge. I know that seawater and Vibrio go together, and doxy goes with Vibrio, so I can knock this question out super fast. And also in clinical practice, I'm going to add doxy to all my other stuff. All right, so is this useful too? I hope it's useful. The show here is called Invictus Reviews. This is the free podcast. We are busy building the full program, and the full program is going to be much different than anybody else's board review. Much bigger, much better, tastes great, less film, awesome. Watch the bit, herb it out, talk to you soon. Bye for now. Boom.